we are moving now to the second eminent scientist in the field of anesthesia, Professor Abdelazeem Eldawlatly. He is a professor in the King Saud University, King Khalid University Hospital, and he is interested all the time in the field of the thoracic and other fields of anesthesia, but he is interested mainly in the thoracic anesthesia, and he will deliver for us today one of the important lecture about the update in the thoracic anesthesia. So please, Professor Eldawlatly.
Thank you very much, Dr. Essam, for this nice introduction. My topic tonight is on the thoracic anesthesia. I'm going to give you an update on the latest development in this field. Actually, we are doing the adult thoracic anesthesia. Regarding the pediatric thoracic anesthesia, and the neonate one is performed by our dear colleagues in pediatric anesthesiologists, and it is dealt with the pediatric surgeons. So I'm here disclosing that there is no conflict of interest of any of the products I'm using. I am an end user of these products. This is the lecture outlines on the lung isolation techniques, double human tube issues in terms of size, insertion depth, bronchial blockers, protective ventilation, pain relief following thoracic surgery, and I'll end with summarizing the whole issue. Regarding the lung deflation and isolation techniques, it's broadly divided into two methods. Method A is from without, and method B is from within. What I mean by without and within, without means not using the tracheobronchial tree, means you have to use a single human tube and insufflate CO2 in the chest cavity, in the pleural cavity, and this will lead to lung deflation. From within means you are using the tracheobronchial tree, using either double human tube or bronchial blockers. From without technique, we are using most oftentimes in cases like bilateral sympathectomy patients under general anesthesia, where we use a single human tube, and at the time when the surgeon is going to use a varus needle for CO2 insufflation and trocar insertion, we used to stop ventilation altogether in order to avoid any injury to the lung. Then the surgeon started to put the CO2 insufflation. Usually on the right hemithorax, we used to put up to pressure of 8 to 10 millimeter mercury, and on the left side from 6 to 8 millimeter mercury. And this is more than enough to deflate the lung or collapse the lung. Tidal volume is 6 milliliter per kg, and this is the respiratory rate. And then at the end of the procedure, CO2 off, and then the surgeon is putting this elastic tube underwater seal, whereby the all CO2 which is accumulated chest cavity is removed. Then manually ventilate the patient and put the patient on the ventilator. Usually you put the patient on high PEEP at the end of the procedure. And this is going to be repeated on the other side in case of bilateral procedures, and the patient then shifted to PACU. We have had no problem with this technique whatsoever, but you have to be very alert, in terms of to monitor the pressure of the capnothorax on either if you operate on the right or if you operate on the left. Usually hemodynamic instability occur more on the left side due to the pericardium, of course. On the right side, there is usually no problem with this technique. This is our publications in this field, whereby in thoracoscopic sympathectomy, this is endo-bronchial versus endotracheal anesthesia. Actually, these publications are all quoted and well cited in the literatures. We'll move to the double human tube issues, right side and left side. So we go for identification and indication. Then we go for the size and briefly on the airway trauma, secondary to double human tube insertion, and then we go to the new subject, which is the insertion depth. Right and left, I think all of you know about it. This is the endobronchial portion of the right-sided tube, where you find the slot on the right, on the endobronchial portion, which has to be positioned using fiber optic bronchoscope opposite the right upper lobe bronchus orifice. And this is the how to identify the right side from the left side tube. There is a few indications left for the right side tube, which are usually all of us is using now left side double human tube. The indications for right side double human tubes as follow: left main stem bronchus obstruction, left main stem sleeve resection, left tracheobronchial disruption, anatomic distortion, making left main stem intubation difficult, thoracic descending aortic aneurysm, and left pneumonectomy. So these are the things where you have to use the double human tube. The left side, the double human tube, there are two new tubes I would like to show you in video in a minute. So this is the cell bronch, which is made of the silicone. The other tube, which showed you earlier, was from PVC. And this is silicone material. You know, the silicone is a bit expensive, and it is not going to be affected by patient temperature, not like PVC. Besides, there is a reinforced end here, a tip, you know, whereby it is not going to be kinked. So this is the advantage of the cell bronch or the silicone tube. Another nicely well-developed tube, double human, also left side double human tube, which came to the market recently, which is called the triple human double human tube or the anchor tube. This is Korean made, whereby I'll show you in a minute a video also on it, where there is here a balloon which accommodates 6 cc of air. This balloon, when you insert the tube, is going to be anchored to the right tracheal wall, and while pushing it down, the tip of the left side tube go directly to the left side without inadvertent insertion to the right main bronchus. So this is the advantage of this balloon here, or the third balloon, or the third human, which is the green one here. I'll show you in a minute the video. The double human tubes issues, as I said, you know the size. For example, beside the identification of the tube, then you go for the size. Size of the double human tube is an issue because there are 2 methods which are used to predict the size of double human tubes: the measured and the conventional. Measured side, this is the Brodsky, if you look to this table, measuring the tracheal width using the chest X-ray, and measuring the bronchial width using diameter using the CT scan. So this can be, you can use this, either this or that, but mind you that there is an addition of 10% increase due to the imaging. So you have to deduct 10% from each of these figures. So if the measured tracheal diameter is more than 18 and measured bronchial diameter more than 12, you go for left side double human tube 41 French. You can use it, it's a bit cumbersome, and I think is not practical. Slinger came and gave us a simple and nice example, which is based on the patient height. For females, 160 more centimeter height, use 37 French. For male, more than 170, use 41 French, and so on. So this table you can also use. There is a new subject here on the use of ultrasound, whereby the tracheal diameter ultrasound is identified. And here, if you go with this one, you know, you have to, that the double human tube selected as follow, that the 37 French use for the tracheal diameter using an ultrasound more than 14 millimeter. And if 35 French tube to be used, tracheal diameter ultrasound nearly 14. And if you use 32 French, tracheal diameter using ultrasound is 13 millimeters. So this is just to measure the tracheal diameter using the ultrasound using, and then you can select the tube as in this table. Let's go to the conventional one. Conventional one that every anesthetist is using, that we used to go for 37 or 37 French for females, or 39 or 41 French for males, depending on the stature of the patient, how tall, how big, you know, then you can select the tube. However, with this kind of tubes and these selections, airway trauma is reported. And here, this is a very interesting subject, and the report came in 2020, airway rupture caused by double human tubes, review of 187 cases. And this is just published in the last year in the Anesthesia Analgesia. And they have 187 patients. Most of ruptures were in the trachea and left main bronchus. In the trachea, around 98% of the reported cases, and in the left main bronchus, around 37%. And the etiology of this rupture or trauma to the trachea or bronchus was due to the stylet, cough over distension, multiple attempts to adjust the position of the double human tube, difficult intubation, use of an oversized double human tube. And here I wanted to draw your attention to this. This is a particular importance in our practice, which is use of an oversized double human tube. Most of the airway ruptures were diagnosed intraoperatively. It leads this rupture to pneumomediastinum, air leak, hypoxemia, and subcutaneous emphysema, and all were surgically corrected. However, make a note here that the mortality of patients with airway rupture was 8.8%. There was mortality following airway rupture, around 9%. So this is kind of some figures to show you the rupture. Here's the bronchial rupture. This is published in 2003. And this one is another iatrogenic tracheal rupture during intubation with left side double human tube. And you see here the scar, after repair of it. And this one not yet published. This is in the Journal of Cardiothoracic Vascular Anesthesia, tracheobronchial trauma from double human tube placement in patients undergoing lung transplantation. This is going to be published in 2021, might be published by now. There's also trauma here. And these are all caused by the double lumen tube. And this is another one, tracheobronchial injuries. This is also published in the chest, 2019. And here you can find, even the stent inserted to overcome this rupture here. You see these things here. So the recommendation is that the size of left side double human tube selected in our practice now and for the last 7 years, I'm using 35 French for females and 37 French double human tube for males. I never used 37 for females, except rarely, according to the stature of the lady, and even never used 39 or 41. For sure, 41, I didn't use it for the last 7 years. But 39 might be if I have a giant patient, which can accommodate 39. But the bottom line or the basics of our practice, 35 French for females and 37 French for males. Anticipate difficult airway. If you anticipate the difficult airway, you have to go one size down with the left side double human tube. Avoid forceful intubation. Remove the stylet as soon as you pass the bronchial cuff, passes the vocal cord. Fiber optic bronchoscope should be used routinely. There is no consensus here. Tracheobronchial cuffs should be inflated slowly. Both cuffs should be deflated when the tube repositioned. If you want to reposition the tube, you have to deflate the cuffs and reposition the tube, then inflate the cuffs slowly. Remember, everything has to be according to this schedule. I'll show you one video on left side double human tube insertion, whereby you will see with fiber optic the cuff herniation and how we adjusted it. I hope you can see the video. There is a tube inserted. This is the cell bronch tube. And here the cuff is herniated above the carina. We have to deflate it slowly and push the tube down to the left main bronchus. Okay, and then you push it down, and then you secure the cuff again. And if you see here, right main bronchus, and here right upper lobe bronchus, which is the like the Mercedes sign. And this is one of the patients whereby you can use the tube, and here we can use the. I just showed you the would like to show you the CPAP. You know, CPAP can also be attached to the collapsed lung in order to improve oxygenation if interoperative hypoxemia during one lung ventilation occurs. The thing is that there is, as I said, there is a misplacement of left side double lumen tube. When you insert it to the left side, it goes inadvertently to the right main bronchus. This report shows you the incidence of this mishap and risk factors and how to reposition this one. So the results of this is in 48 cases out of 1,135 cases, incidence of 4.2%, that the tube, left side tube, instead of going to the left main bronchus, it inadvertently goes to the right side. And this is usually happen, as in this report, in females and short stature patients, and in the use of small sizes double lumen tube. So these are the three things which they mentioned about this tube, or this misplacement of the left side double lumen tube. It can happen. By the way, this is routinely happen, but what we do in this case, we don't consume the tube or throw the tube. No, we just go to the bronchial lumen and withdraw the tube with the fiber optic bronchoscope under guidance of fiber optic bronchoscope, and then redirect the tube to the left main bronchus and railroad the double lumen tube and over the shaft of the fiber optic bronchoscope to the left main bronchus. It's easy, it is not difficult. So I think in that case, this tube has got an indication, which I showed early, the anchor tube or the triple lumen double lumen tube. As you see, this is a silicone material here, and this is a cuff which is inflated with 6 cc air, which anchor to the right tracheal wall. And here I'll show you how we can prepare it. We have a couple of samples of this, which we have used. I think it's a very nice tube, and came to exist, you know, it's not going to disappear. Six is here in the green cuff. Direct the left endobronchial portion to the left side. Okay. So I'll show you a couple of examples. This is one example. This is our resident. You know, he is R2. You know, he is practicing this double lumen tube. Or R1, yeah. I'm not sure which R. So now he's inserting and count up your fingers after passing the vocal cord to the left side, and then we inflate it, as you see here in this schematic, you know, then after passing the vocal counterclockwise and go down, and then inflate the green cup with 6 air. And remove the stylus. This is the time to remove the stylus. Push the tube with the stylus inside. Then slowly resistance, not going anymore. The resistance means that the green cuff hits the carina. Yeah, not going anymore means this is, then you deflate the green cuff and connect the patient to the ventilator. And here is another view. Is the video okay, Dr. Essam?
Yes, Prof, but to some extent it is very slowly moving.
Slow, huh?
No problem, but it is clear. It is clear.
That's clear. Okay,
yes.
Thank you. So this is the same thing, you know, with the inflation of the, we deflate now the green cuff and we push the tube until you know, inflate the green cuff with 6 cc air and then push the tube until there is resistance, you know. Now this means that the cuff, the green cuff is at the level of the carina. Then you deflate it and inflate both other cuffs and fix the tube. Okay, sorry. Oh. Sorry. Okay. Now we move to the insertion depths of left-sided double lumen tube. And this is a new subject, and we have a couple of work on it. These are the insertion depths of the left-side double lumen tube formulae. These are in the now in the literature, Brodsky formulae, Beck formulae, Chow, Taketa, and Lin. You know, these are the different formulas. So we thought to have our own formula, which is suitable for our patients. So we studied it on 41 adult patients, and we came out with a formula, which we published in SGA in 2019. This is a formula which came out of our study, where this is the insertion depth in centimeter, and this is the height. This is the left-sided double lumen tube. We correlated the height to the insertion depth of the double lumen tube. It was well correlated, and we came out with this formula, which you see it on the screen. To make it easier, we make a program for this formula. I'll show it later. This formula, we have attested it in another study, and we published in Anesthesia Intensive Care on the efficacy of height-based formula to predict the insertion depths of left-sided double lumen tube. This is prospective observation of the study on 66 patients. Left-sided double lumen tube without further adjustment was in 45%, 45 patients out of 66, success rate 70%. And there is a tube which is either we advance it a little bit in or withdraw a little bit out in 18.2% of patients, 12% without any airway obstruction. If we add 17 and the 12, so the success rate will be around 82%, which is fairly accepted. Currently, we are doing the study on, we are aiming to have 100 patients in order to verify our formula. Our formula, we managed to have it on the Android smartphones, and this is the application. If you go just on the Play Store and then just write L capital, D capital, L capital, T capital, left the double lumen tube, then it will go to this icon, and then you can install the whole program. And if you want to run it, they will show you here. Here you have to put the patient height. Sorry, you have to put the patient height, which is here, as you see here, 170, and then ask for calculation. It gives you the insertion depth 27 centimeter from the corner of the mouth. So this is how to use this one in the smartphone, which is Android. Or you can use this smart calculator on the left side of the screen. Also, you just feed the formula, and you can start to have the calculations. It's easy, it's handy, you know, in your theater, you can have the mobile phone. Once a patient is in, I used to ask my residents just to have the patient height on the patient note, make it clear, the patient height is endorsed to everybody, and then use this calculator, and then you can have the insertion depths. What is the idea of this insertion depths? Insertion depths might, I'm not sure yet, but it might reduce the time for checking and the fixation of the left side double human tube. We are investigating this currently. We'll move to the bronchial blockers. We have two types. We have dependent bronchial blockers, and we have independent blockers. Dependent blockers, which is the torque control blocker or univent. This is a Japanese product, Eno tube, they call it. This is the thoracic surgeon who invented it from Japan. Independent bronchial blockers, we have wire-guided endo-bronchial blocker, which is George Arnett from Wisconsin University. Tip deflecting endo-bronchial blocker, this is Edmund Cohen. And uniblocker is Fuji blocker. Is blocker, this is from Netherlands. And Taba blocker, this is a new Chinese product. We'll go one by one. So this is dependent blockers. This is the TCB or torque control univented tube. This is single human tube with different sizes. There is a pediatric size of 3.5, 4, 4.5, 5, 6 millimeter, and so on, whereby the blocker is attached to the anterior shaft of the tube, single human tube, but is not coming out. That's why it is dependent on the tube. And here this will show you how this we inserted, all using the fiber optic bronchoscope guidance. You go with the fiber optic bronchoscope. And then once you visualize the carina, this is a posterior part, which is membranous, and the tracheal rings anterior. And here you can see the right main bronchus, upper lobe bronchus orifice, right main bronchus, and left main bronchus, and carina. Now we are going to push the blocker to the right side. You will see now. Now it's pushed to the right side, and then we inflate the cuff. The bronchial cuff accommodates from 7 to 10 centimeter air. Okay, and you can adjust it as you like later on. So this is regarding TCB. We have now the independent blockers, which is wire endo-bronchial blocker from Arnett blocker. You know, all independent blockers, they have four-way adapter, as you see here in the screen, four-way adapter, and the blocker itself. You know, the adapter is one port for the blocker, other port for the fiber optic bronchoscope, and third one for the respirator, and the fifth one to the catheter mount of the tracheal tube. This is how in application with two of our patients, an adult and pediatric. And here an adult, you know, it's very suitable for a pediatric population, by the way. It has two sizes, 9, 6, and 5, 3 sizes. And size 5 and 6 can be used for pediatric, and size 9 can be used for adult. The other one, which is tip deflecting blocker, which is Cohen blocker. Difference between Cohen and Arnett blocker, that the Arnett blocker, I'm sorry, I have to go back here. The Arnett blocker has got loop here, which is a nano loop, whereby the shaft of the fiber optic bronchoscope go through and will be held, you know, using this. There is like a key, you know, on the proximal part of the blocker, which you can pull out, so it will tighten the nano loop over the shaft of this fiber optic bronchoscope, and then you go together under fiber optic guidance. You put where you want. In the tip deflecting Cohen, there is no nano loop here. There is tip deflection, and there is an arrow here to show you that you are in the right side or left side, and this is controlled by this one, which is a wheel on the proximal part of the bronchial blocker. This is you directed with this wheel, either right or left, and then guided with this arrow. This is Fuji uniblocker. Fuji uniblocker is it's centrally channeled blocker. There is a central channel here open, and it can also be used. It has also four-way adapter, and this is the cuff which can accommodate 7 to 8 centimeters of air, and it's also of the silicone type. It's I rarely use it, you know. I was using it, you know, several times, but I found it, you know, it's easily dislodged from the bronchial tree, so I'm not using it anymore. And here is a new one, which is the TAPA blocker. This is Chinese product. I think I have to, I don't know, but this is Chinese product, you know, with the same idea. This is like a prototype of the Fuji blocker, also with the same problems, and I have a couple of samples, but I didn't like it. Then we go for the ACE blocker, which is a very good type of blockers. I'm using it oftentimes. This is a catheter with bifurcated tip, you know. This is catheter with bifurcated tip here, and whereby this bifurcation will sit on the carina, like riding horse. I used to call it like riding horse. And this cuffs, one cuff to the right main bronchus, and the other cuff to the left main bronchus, and you can identify it externally through the color and the markings on the external balloons outside. This is how it is in place. Single human tube. Use the widest acceptable single human tube or accommodated single human tube for the patient, and then you connect the four-way adapter, and then you can pass the ACE blocker. This is how you can we insert it. This is a view from outside. This is the ACE blocker, lubricate. This panoramic view for the whole thing. Then then you fix, you insert the ACE blocker. Followed by fiber optic checking. If you look to the screen, you will see that we push it, and then it will go. One lumen will be in the right main bronchus, the other one will be in the left main bronchus, like overriding the carina. You see, right and left. It's inserted easily with certain manipulations. You can have it. There's another one, another view for the same tube, same blocker. This might be a better, clear view. I'm sorry that the names of the patients appearing here, I don't know how to hide or remove. Once the video is playing, you know, they are exposed, you know. But I'm sure Dr. Saad is going to deal with it for editing purpose. So this is a carina. You can see very clear, right side, left side, main bronchus. And then we're going to push the tube. This is the bifurcated ACE blocker. With certain manipulations and sometimes I used to do external laryngeal manipulations from outside. And this will help a lot, you know, in passing it. You can see it's now inside, like riding the carina. Then you inflate the balloons according to the site of surgery. This ACE blocker can be used also in case you have a tracheostomized patient like this patient. This patient was operated in a cardiac theater, and he came back for some other procedure, and they wanted to have the lung isolation. So we use the this ACE blocker as well. tracheostomy tube, and you fix the adapter 4-way. My date is hanging there, yeah. You have to have an assistant because one has to pass the blocker and the other one has to use the fiber optic bronchoscope. It has to be a quick procedure for this patient because this cardiac patient, he cannot tolerate hypoxia for long time. You have to here now it is structure now. I know that you cannot see now, but now you can see the video. Now I just want to confirm yeah, now this is now overriding already on the
just you put it at the carina.
yes.
Riding the carina, like riding the carina. Exactly. Oh, yeah.
You see now? It's very clear.
Now to
one
see the extensive
here, I don't inflate either of these.
we're okay, huh? Airway pressure is fine. You can ventilate, yes? So I'll show you this. This is the right side drop. Okay, I now inflate one balloon now. Yes. I'll tell you which one. So this is the left side. Left side, okay.
So this balloon here is inflated, you can see.
On the right side. So this is left and right.
You have to identify first which one is right, which one is left. You inflate the balloon.
This is the right side, right.
And mark this only balloon outside.
This is the right side. That's the right side. The left side of this. 7 to 10 cc. Right upper level.
Actually, I don't know how
yes.
to. Okay. Oh, that? Sorry. Okay, so we'll come to this table which shows you the different blockers: Arnold blocker, Cohen blocker, uni blocker, Ease blocker. The different characteristics of each. Size: Arnold blocker, we have 5, 7, and 9 French. Cohen only one size, uni blocker one size, Ease blocker one size. Balloon shape: spherical, and all the same. And the guidance here: Arnold blocker, there is a nylon loop. Cohen blocker, there is a wheel at the proximal end of the blocker. Uni blocker tip deflected already, and Ease blocker there is bifurcated tip. Tracheal tube size, the biggest size ever you can use, either 8, 8.5, which it's better to use the highest possible size, single lumen tube. The diameter of the intraluminal, is 1.4 millimeter Arnold blocker, 1.6 millimeter Cohen blocker, 2 and 2 uni blocker and Ease blocker. This means that the deflation is faster with Ease blocker, uni blocker compared to the Cohen blocker and the Arnold blocker. And this is maybe an advantage of these two, uni blocker and the Ease blocker. But there is a procedure if you have a blocker how to speed deflation of the operated lung using bronchial blocker. First, you disconnect the patient from the respirator, deflate the pilot cuff of the blocker and wait for 10 seconds. Then inflate the pilot cuff and connect the patient to respirator and repeat this twice, supine and lateral decubitus position. And then you will find that the lung is faster deflated. You know, we need this, especially nowadays, most of the cases are done thoracoscopically. This is the chart, you know, which I'm using for teaching of our colleagues, you know, whereby all these kinds of tube is attached, and we used to work with it in the workshops. Then let us move to the enhanced recovery after thoracic anesthesia. I'm not calling it enhanced recovery after surgery, but you know, enhanced recovery after anesthesia, or enhanced recovery in this particular format after thoracic anesthesia. Why I do that?
Bro,
because most of the criteria. Faddal.
Can we get the slideshow, please?
Sorry. Okay. So most of the guidelines are anesthesia-related issues. It is not surgical-related issues. Few surgical-related, but most of the rest are anesthesia-related issues. Here, there is a report on the guidelines for enhanced recovery after lung surgery, recommendations of enhanced recovery after surgery, Society and European Society of Thoracic Surgery. I'll show you now what I mean by that. So here you can see the preoperative phase. You know, the preoperative information and education. It is of low evidence, but a strong recommendation grade, and so on. You know, this might be not of our interest. This perioperative nutrition and oral nutrition, this is surgical value. Smoking cessation, this is our interest. Smoking should be stopped at least 4 weeks before surgery, and the evidence level is high, and the recommendation grade is strong. The other thing, the anemia management, also the same, it's high and strong. And here the preoperative fasting and the carbohydrate treatment, clear fluids also up to 22 hours before induction of anesthesia. There is a high evidence level and a strong recommendation grade. The pre-anesthesia medication, routine administration of sedatives to reduce anxiety should be avoided. Moderate evidence level and a strong recommendation level. And the antibiotics to be given, there is high evidence level and a strong recommendation. Of course, antibiotic we are giving it within 30 to 60 minutes from commencement of surgery according to WHO regulations. And this is our duty in the OR. And here there is prevention of interoperative hypothermia, high and strong recommendation, high evidence and strong recommendation. You know, our role in prevention of surgical site infection, 3 things. One of them is maintenance of normothermia. This is our duty intraoperatively. The other thing is the wearing gloves and hand hygiene. The third thing, as I said earlier, is giving the antibiotics timely within 30 to 60 minutes from commencement of surgery. Standard anesthetic protocol, here the advice for lung protective strategy should be used during one lung ventilation. The evidence level is moderate and the strong is recommendation. Combination of regional and general anesthesia technique should be used. Short-acting volatile anesthetics or their combination are equivalent choice, either volatile anesthetics or intravenous. Then post-operative nausea and vomiting control, non-pharmacological measure decreases the baseline of risk, should be used in all patients. Multimodal pharmacotherapy, I'll show you what are the drugs to be used in post-operative nausea and vomiting. Regional anesthesia and pain relief, here to my surprise, they wrote paravertebral blockade provided equivalent analgesia to epidural anesthesia. I think I have to revise this, but you know, that's what they put, and it was a high evidence and a stronger recommendation. I'm not sure in thoracotomy, I don't think paravertebral, I'm not sure. Maybe some of our colleagues in pain specialists will tell us, but from my experience, if I have a thoracotomy patients, I agree if there is a thoracoscopy patient, but if thoracotomy patients, I don't think paravertebral will be enough for the patient. Then combination of acetaminophen and non-steroid anti-inflammatory drugs should be administered regular to all patients, unless there is contraindication, high evidence, and strong recommendations. The fluid management here, also another interesting point, very restrictive or liberal should be avoided. So the aim is to, or for eovolemia. So this is the aim. You have to have your patient eovolemic, no liberal fluid and no very restrictive fluid. So these are the things which I found, regarding this. So coming back to the post-operative nausea and vomiting, I'll just refer you to this position statement, which just published in the Surgery for Obesity and the Related Diseases, whereby it is stated very clearly that multimodality is important, or 2 to 3 medications to be used, mainly the dexamethasone and or ondansetron or granisetron, and the other non-pharmacological measurements also has a role in this. One of it is the intravenous fluid therapy. So just refer you to this article, read it, and I think it will cover the whole issue. This published in 2021. Let us move to the protective one-lung ventilation, which is a hot topic nowadays in our field. This is the purpose of what protective one-lung ventilation is: to keep the lung open, to minimize lung injury, ensure adequate gas exchange, and the approach is low tidal volume, high PEEP, high E ratio 1:1, and alveolar recruitment maneuver. And this is the alveolar recruitment maneuver and how we do that. I hope it will appear. This is single step, whereby you have, and this is the multi-steps, I think all our, and they have here ventilator, they have, this is ventilator driven one. So I just show it again. Here, this is the steps, and here you can have, and here, if you look here, this is the plateau pressure, and here is this one is the, sorry, this is the delta pressure, and this is the plateau pressure of the airway, which is 37 millimeter mercury, and this is the PEEP. The difference between the plateau pressure and the PEEP is the driving pressure, or what they call it, the delta pressure. And then you press on the start and let it go in steps wise, like this. Here is the steps, the airway pressure, 25, 30, and so on. It goes up to 40, and the PEEP, it goes from 5 to 20, and then PEEP detrimental trial, PDT, it goes down, 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 each to from 18, 16, and until 8. And this is the one trial for multiple steps of alveolar recruitment maneuver, and then you end with the PEEP detrimental trial. This can be repeated. Usually, we do that in some patients in two occasions. The first, after induction and intubation, I do it once, and upon recovery, before removing the tube, also I do it once. It might be possible you do it interoperatively also, but mind you, if the lung is emphysematous, it will be a bit dangerous and risky, so you have to be very cautious if you apply it in one-lung ventilation. There is no, there is many papers which address this, but none of the papers prove that this alveolar recruitment maneuver has a prophylactic effect on the post-operative pulmonary complications. The driving pressure during thoracic surgery, and this is also one of the papers published, that the application of driving pressure guided ventilation during one-lung ventilation was associated with lower incidence of post-operative pulmonary complications compared to conventional one. This is only one paper which was brought to this. In this regard, we have studied the effect of low versus high tidal volume ventilation in dogs. And this is what we do. And this is the dogs after anesthetized dog. And this is surgery, what the surgeon is doing, opening and take lung biopsy. And then we send, this is for histopathology and for inflammatory markers and for neutrophil infiltration assay. So this is the thing which we did. And we found that, with a high tidal volume, the neutrophil infiltration is massive, for histopathology. Low tidal volume, the things are quite okay. So we recommend the use of low tidal volume rather than high tidal volume. There is a study here on the use of high versus low PEEP, which is the brother study This is in 1122, 2020 was established, and now they are recruiting patients. We are now preparing our documents to get an IRB approval to join this study. We have got an approval from the main authors that we can join it, but now we are preparing our documents. I hope this will eliminate which PEEP to be used during one lung ventilation, high, low, or what. Three things I'm going to finish with is the coming to, I think these three subjects are going to come for a study in the near future in thoracic anesthesia. There are an issue on the intubated and non-intubated lung surgery. You know, this non-intubated lung surgery in the Korea and Chinese is widely spread. And, you know, actually there is no reason to use it if I'm going to give a general anesthesia, that what we are doing now, and intubating the trachea. We have no problem with that. But you know, this is one of the procedures which are now practiced especially in Korea and Chinese, and they have a study here on the intubated versus non-intubated patients, and they showed that the inflammatory response for non-intubated patients, thoracic surgical patients, lower than the intubated patients. So degree of inflammation or risk of post-pulmonary complications will be lesser. Another hot topic and study here on the hypercarbia and the inflammatory response to lung ventilation. And this is also showed the same. This is the gray one, low inflammatory response with use of if you allow hypercarbia or permissive hypercarbia during one lung ventilation. Still, there is no much enough data, and these two studies are low power, so we cannot rely on them, but I think it's a hot topic in the near future. Effect of anesthetics on inflammatory response also is another hot topic, which they compare the sevoflurane versus propofol. And you see here all studies where they favors of sevoflurane as anti-inflammatory response versus propofol. Also, this is underpowered study, but I think these are the three subjects which will come for research in the near future in thoracic anesthesia. We cannot leave this panel without saying a few words on the anesthesia management in thoracic surgery in patients with suspected or confirmed COVID. I'll just refer you to this interim of the Saudi Anesthesia Society guidelines, where you can find everything on this subject. I'll show you here one of the procedures which we do, and just to show you the amount of how we do that. This best excavatum, and here in best excavatum you have to insert the double human tube left, and you have to put thoracic epidural for this patient. So this is one of the procedures which we do oftentimes, and the other one is robot assisted. As you see, this robot assisted here, the consoles, they are moving, touching maybe the patient's soft tissues, so you have to be very careful in that regard. And here, this is radio assisted also. This is robot assisted thymectomy surgery. You can see the other pleura is open and the lung is moving. So the both pleurae are open. Imagine how will be the ventilation. So perileaf following thoracic surgery, as I said, the thoracic epidural is still standard for thoracotomy. This is my point of view. You know, I'm not in agreement with the consensus of paravertebral for thoracotomy. But anyhow, for VATS and RATS, paravertebral and erector spinal plane block is a good choice. Either VATS or RATS, which is robot assisted. This epidural, I used to do epidural thoracic while the patient on lateral position. I never did it while the patient is sitting. So loss of resistance, then you pass this catheter. And this one is the erector spinal plane, a paravertebral, and this one is the erector spinal plane. You can see here trying to find the way the transverse processes here and there, and then you go until you reach here and inject the local anesthetic. And here paravertebral space, you injected local anesthetic, you can see the down placement of the pleura. And this is the idea using ultrasound guidance. These two techniques are very easy to be used. In summary, average anesthesiologist should master anatomy, tracheobronchial tree, fiber optic bronchoscope, chest X-ray, CT scan reading, left side double lumen tube size and insertion depths, and one type of bronchial blocker to be mastered. This thoracic surgery and anesthesia is a model for proper communication between the surgeon and the anesthesiologist. Thoracic epidural analgesia for tracheotomy, erectospinal plane block, paravertebral invades and rents. This is a special issue in September 2021. We published on thoracic anesthesia. It has got 13 review articles on thoracic anesthesia covering all issues, including the non-intubated thoracic anesthesia. And this is our fellowship program. And we have 3 fellows so far in thoracic anesthesia graduated. The 4th fellow with us now. And this is the thoracic anesthesia workshops, which we started in 2003 in our hospital. And this is a couple of pictures to show the candidate under training. And here in Paris, we have also, during WCA, we have put our workshop agenda over there. And this is a couple of pictures, Riyadh 2005. And here, Professor Peter Slinger was us in one of the workshops. We invited him to come. And then in Luxor, this is one workshop we've done. And in Riyadh also. And this is Javier Campos here in the middle. He is also pioneer in this field. We invited him to come with us. And in Oman, we went there also for and in Cairo in February 2007, Cape Town in 2008, Riyadh, several ones in Riyadh, Cairo, April 2012, in Riyadh also 15, 14, in Riyadh 14, in Medina, Munawara 2014, also we did it. And the INSAS conference, our conference, Saudi Anesthesia Society Conference 2018 in Riyadh. And here, the last one, which we have done in March 2021 for our residents. And this is how it looked like. So that was all. Thank you very much for listening.
Thank you, Prof Abdelazeem, for this very informative lecture. And it is full of information and knowledge. And I think we will consider this lecture as a reference in thoracic anesthesia because you covered everything. And I think it is not easy for anybody to go for thoracic anesthesia. And he have a lot, and he should go regularly in the thoracic anesthesia theater to be familiar with these very skillful techniques. Please, we have some of the questions. One of our colleagues, he asked about, can we decide to use bronchial blocker or double lumen tube pre-operatively by using radiological imaging, chest X-ray?
Chest X-ray and radiological imaging pre-operatively, you can use it for detecting or predict the size of the double lumen tube you are going to use, but it's not to differentiate between double lumen and bronchial blockers. But if you have a patient, for example, pre-operatively you examine, and you find the patients to have difficult airway, then there is a good place for bronchial blockers to be used.
Okay. Another question, what is the role of vent-train device, even ventilator and ECMO in thoracic anesthesia in your experience?
Yeah, okay, this, we have recently one patient whereby, you know, this was superior mediastinal tumor, and the tumor was pressed and invading major vessels. You know, in that case, you know, ideally you have to put the patient, you know, femoral bypass. It has to be inserted before surgery and avoid anything to be given in the neck of the patients. And in that case, you know, you have to call for the help from the cardiac anesthesiologist as well as the perfusionist to be all the time thereby in the theater. So yes, there is a good indications for femoral partial bypass to be established before surgery, because at any time the patient can go for injury to major vessels, and it will be really tragedy, you know, a disaster if this happens, especially in the superior mediastinum. You cannot control any vascular injury.
Okay, Prof. One question from me, Prof. From your experience, as a primitive question, which do you prefer after prescribing all of these tools in lung isolation, double lumen or blockers? This is one. And if you are going to send the patient, for example, to post-operatively to the ICU for ventilation, do you prefer start what type of the double lumen tube or other tubes?
This is not primitive question. This is very tricky question, by the way. This is very difficult to answer because, you know, we cannot say which of which, but, you know, there is indication for each. But the bottom line, which I used to advise everybody if you want to practice thoracic anesthesia, is to master left-sided double lumen tube. Left-sided double lumen tube fits all purposes. This number one. If you have a patient, difficult airway, or you cannot place double lumen tube, then you go for bronchial blocker. Which bronchial blocker? It depends on the facility, your facility and resources. You can use univenti tube or Arnold blocker, Cohen blocker, or East blocker. If you ask me personally, which one I prefer out of this, East blocker.
Excellent. Adding to Prof, you stressed about thoracic anesthesia. I received the message like this: thoracic anesthesia without fiber optic bronchoscopy, it is impossible. Am I right?
Yes, I agree. I agree. You know, there is no consensus here. You know, you cannot, you know, have a middle solution. There is no consensus at all. Without fiber optic bronchoscope, I don't think you can practice anesthesia. If you practice it, well and good. But, you know, it's up to you. You will be responsible, you know, and the patient life will be in not safe, you know. So anesthesia patient safety should be a standard of care for all of us.
Thank you so much for both the eminent speakers, Professor Doyle and Professor Eldawlatly. And last, I find the thank them and appreciate their time